Hello, my name is Dr. Brian Raid, and this is a presentation on Prolotherapy and Platelet-Rich plasma therapy for the treatment of pain. I have no financial interests in prolotherapy or platelet-rich plasma therapy or any other topic discussed within this presentation. The objectives of this presentation are to go over what Prolotherapy and PRP are used for. So I'll go over some case studies to give examples as to what it looks like to be used in practice, how the therapy works, what the procedure involves, whether it's safe, some of the limitations to Prolotherapy and PRP, and then I'll also provide a list of some selected references from the scientific literature. So if anyone has the question of whether these therapies have been scientifically validated, then the answer is yes, they have been. A quick note on who I am. I'm a naturopathic doctor. I practice in Halifax, Nova Scotia. I graduated from the Canadian College of Naturopathic Medicine to do my naturopathic training. In my practice, I specialize in treating chronic infections, chronic pain, integrative cancer therapy, autism spectrum disorder, neurological disorders, and basically anything that's chronic or treatment resistant. I use a number of different IV therapies in my practice. I do a number of injection therapies, including Prolo and PRP, of course, but also ozone, neural prolotherapy, and neural therapy. And I use a number of other tools in my practice, including herbal medicine, endobiogenic medicine, pulse electromagnetic field therapy, or PEMP therapy for short, bioresonance therapy, methylation testing and support, and thermography testing, amongst a number of other tools. Prolotherapy and PRP are essentially used to do the same things. I'll discuss in some upcoming slides the difference between the two therapies, but as you'll see, they're ultimately trying to do the same thing, and that's ultimately to try to heal damaged tissues. So because of that, Prolo and PRP are really indicated for treating arthritis, and that could be affecting any type of joint. That's typically going to be osteoarthritis, but it could be used to treat some of the sequelae of inflammatory arthritides like rheumatoid arthritis, for example, or reactive arthritis. PRP and Prolo are also used to treat ligament or tendon injuries. So, for example, if a runner had Achilles tendinopathy, then it could be used to treat that. Muscle injuries are an indication for PRP or Prolo, such as a rotator cuff tear. Disc herniations can also be addressed with Prolo or PRP. Ehlers-Danlos syndrome can respond well to both treatments, persistent post-percussion syndrome, and then it can also be used for sports injury prophylaxis. So there are some athletes who will have preemptive PRP or Prolo done to help reduce the risk of them tearing a ligament or tearing a muscle, for example. To my understanding, there are some professional sports teams that routinely do this because in their given line of sport, it's quite common that say for professional or high-level female soccer players, it's statistically quite probable that they'll at some point tear their ACL in their knee. And so sometimes there are some teams that do prophylactic prolotherapy or PRP to help try to minimize the chances of that happening. The first case study is looking at a case of moderate arthritis. This is a 58-year-old female. Both of her knees were diagnosed as having moderate osteoarthritis. The pain level she was experiencing ranged from anywhere between a 5 and an 8 out of 10, where 10 would be really bad and 0 would be no pain. This patient has some underlying health issues that influence her overall inflammation levels. So when her underlying disease issues, she's suffering from Lyme disease, so when her Lyme disease symptoms are worse, then her pain levels would tend to be worse. Prior to coming to see me, she had tried working with some massage therapy and some Reiki being a type of energy work, and she found that she would get some temporary relief with those therapies from time to time. So sometimes they'd help a bit, sometimes they wouldn't really do much of anything, and she was really struggling with her knees. When she came to see me, I assessed her and I recommended that we do some prolotherapy to both of her knee joints. I added ozone into the mix as well, and as you'll see from the upcoming the subsequent case studies, I use ozone therapy with virtually every injection that I perform. Ozone is something that in and of itself has been shown through a number of research studies to help reduce inflammation, helps to promote tissue healing, helps to reduce pain. And so adding ozone therapy in with prolotherapy or PRP essentially makes those therapies work better. And I'll delve into that in a little bit more detail in some upcoming slides. If you're interested in learning more about ozone therapy, there are many resources on the internet that you can certainly look for. I wrote a review article about ozone therapy specifically for the treatment of pain in a publication called NDNR. So if you search for NDNR and my name, Brian Raid, in a search engine, then the article will come up, and there's a full list of references in there as well for your perusal. So with this patient, I treated both of her knees, so injected the prolotherapy solution and ozone into her knee joints, and a month later she came back. With prolotherapy, the treatments are done with a maximum frequency of once every 3 weeks. PRP, as we'll see, is done with a maximum frequency of every 4 weeks. So this patient lives about 5 hours away, so she came back a month later, which was pretty close to the 3-week mark, and she was doing quite a bit better. Her pain had been at between a 5 and an 8 out of 10, and her pain was down to about a 3 out of 10 on average after the first treatment. So she was pretty happy, and I was happy, and it was looking like we were on the right track. So we repeated the treatment, and she came back another month later, and she noticed an additional benefit to her knees. Her pain was ranging between a 0 and a 3 out of 10. So in other words, sometimes her knees were virtually pain-free. Other times they were still bothering her to some extent, but still not nearly as bad as they'd been before. And so to date, this patient, I'm still treating her for some of the other underlying health issues she has, but on average, every 3 to 4 months, she requests another treatment saying, my knees are starting to act up a little bit, so can we just do some extra ozone and prolo into my knees? And so we do that, and she seems to be doing very well with that. At this point, she's having minor pain that just seems to fluctuate with her other symptoms of Lyme disease when they get worse, but the Lyme disease symptoms are getting better, so the pain flares are becoming less frequent. So this is a fairly typical case that I would, typical types of results that I would see with moderate arthritis, or certainly seeing similar results with mild arthritis as well. So of course, not every case is going to have a fantastic response to any given treatment, but these are fairly typical results based on my experience so far. The next case study is looking at a case of severe arthritis. This is an 80-year-old male. He was diagnosed with severe osteoarthritis, in other words, bone-on-bone arthritis in both of his knees. He was determined to be a candidate for surgery, but he really wanted to avoid it. He didn't want to go through the discomfort of the surgery itself, and he didn't want to go through the recuperation period afterwards, so he came to see me to see if there's anything that we could do. When he presented to my office, he said that on average his pain was about an 8 out of 10 with just general walking around, and going upstairs or downstairs would make it even worse, and he hadn't tried any other therapies before coming in to see me. So with his case, I recommended that we work with some platelet-rich plasma therapy. As I indicated earlier, PRP is quite a bit stronger than prolotherapy, and I'll discuss why in a couple of slides from now. And with bone-on-bone arthritis, I always recommend just starting right with the PRP. We can do prolotherapy, and sometimes it can provide some symptom relief, and with enough treatment, it may yield similar results to PRP. But with bone-on-bone arthritis, it's usually quite a lot faster and more effective just to jump right into PRP. So we started with the PRP injections for both of his knees, and I combined that with ozone therapy as well. He also received pulsed electromagnetic field therapy after each treatment as well. PEMP therapy is essentially a therapy that involves emitting these low frequency electromagnetic impulses into the affected area of the body that's suffering from some type of malady. So for knee arthritis, we put the machine over the knees. For shoulder, it would be over the shoulder. So we treat the area in question. Pulsed electromagnetic field therapy has actually been classified as an FDA-approved treatment device for specific indications. So it's been FDA-approved for helping to expedite healing of certain types of fractures. It's been FDA approved to help treat insomnia and anxiety disorders. So there's quite a bit of research that's been done on PEMP therapy, and we find that when we use it in addition to the injection therapies, patients seem to get better quite a bit faster. So we did the PRP with the ozone and the PEMF treatment, and 4 weeks later the patient came back for a second treatment, and his pain had improved quite a bit. His baseline was 8 out of 10. He found that after the first treatment there was some soreness in the knees for about a day afterwards, and that does happen from time to time. Maybe 15 to 20% of the time there'll be a bit of soreness after the injection, but then after that he noticed a gradual reduction in his pain. So by the time he came to see me after 4 weeks, then his overall pain had gone down to about a 6 out of 10, which was good, definitely a movement in the right direction, and he found that his day-to-day activities were easier because of that. So we treated him again, and treated him several more times actually. So to date, he's done 4 treatments every 4 weeks. His overall pain levels now are between a 3 or 4 out of 10. The activities that he's participating in are quite a bit easier, so he likes to be active. So when he's doing different projects that are of a more physical nature, he finds he can do things now that he definitely couldn't do when he started treatment, say about 5 months ago or 4 months ago. And he's decided to postpone surgery for now because his knees are doing so much better, and there is certainly the possibility that his knees are going to continue to get better. The next case study, the third of the 4 case studies that I'll be going over, is the case of a rotator cuff tear. This is in a 60-year-old female. As part of her job, she did some heavy lifting, and she managed to tear her supraspinatus muscle about 90% of the way. She had done this about a year, maybe a year and a half before coming to see me. As a consequence of that tear, she had a steady pain in her shoulder that was about a 3 or a 4 out of 10, where 10 would be bad, and she found that she had some severe limitations in her activity with the affected arm. So she couldn't lift her arm above her shoulder, above shoulder level. She found that she had a lot of discomfort, and she'd reach for things in the kitchen or when she was out and about and have some significant discomfort associated with that. So similar to the last case, whenever I see a muscle tear, then I'm always reaching for the PRP as opposed to the Prolotherapy, because we usually need something that's that strong to make a really discernible difference quickly with a similar type of case. So with this case, we did PRP therapy along with ozone, and we did this under ultrasound guidance. In our clinic, we have a diagnostic ultrasound machine, and we use that to help guide the needle to the exact location where the tear is located, because that way we can be as precise as possible and get all the beneficial effects of the treatment right to the site in question where it's needed the most. So we did the first injection. 4 weeks later, the patient came back, and she said that her day-to-day pain was reduced. It was down from a 3 to 4 out of 10 down to about a 2, so that was getting better. And she noticed a modest improvement in her day-to-day function, but it wasn't anything too drastic, which is not unexpected after only 1 treatment of PRP in this type of case. So I treated her again. 4 weeks later, she came back in. Her day-to-day pain was still down to about a 2 out of 10. She noticed that her function had improved noticeably more, but it still wasn't a massive improvement. So I treated her again. 4 weeks later, she came back in, and she was very, very happy because her day-to-day pain was virtually non-existent, and her overall function was much, much better. So she found that she could essentially function normally from day to day. When I'd ask her to raise her arms up over her head, the affected arm definitely had worse range of motion than the unaffected arm, which is understandable because there's still a significant tear there, but she had once again a drastic reduction in pain, and her function she was very, very happy that she could just do all the day-to-day things she wanted to do at that point. She was also wanting to avoid surgery for the fact that she didn't want to have to be without her arm for several weeks and as part of the recovery process, and so she was very happy with those results. And the last time I treated her was probably a little over a year ago now. I still see her from time to time because she comes in with a family member that I'm treating for something else, and whenever I see her, I say, "How's the shoulder doing?" And she's still very happy, so she's having a good long-term benefit from that treatment. The final case study is a case study of sciatica. This was a 55-year-old male. He had a history of a disc herniation in his low back, and then he developed sciatica as a consequence of that. He'd been undergoing years of treatment, getting massages, chiropractic work, osteopathic work. He was doing a lot of yoga quite religiously, and he found with all these therapies, they all helped to a great extent, but he found that he had to keep on using them diligently. So he'd have to get his, a massage every few weeks, or he'd have to get a chiropractic adjustment done, every few weeks to kind of keep himself on track. Otherwise, his symptoms would start to slide back. So it was fantastic that he was doing so well with these therapies, but he wanted to see if there was something else he could do to try to see a further improvement. So when he came to see me, he found that his low back and sacral area was experiencing a pain level of about a 4 out of 10 on average, and he was coming in because his sciatica had flared up more recently, and he was about a 5 out of 10 with that. So we started with some prolotherapy plus ozone to his sacroiliac joints, to his lateral sacrum on the affected side, and also some prolotherapy to the posterior aspect of his greater trochanter. And 3 weeks later, he came back, and his low back pain was a little bit better. It was, had been a 4 out of 10. It was down to a 3. The sciatica was no longer daily, and when it was coming on, it was about a 4 out of 10 instead of a 5 out of 10. So we were seeing some movement in the right direction. 3 weeks later, he came back after his second treatment, and the low back pain was a little bit better still, down to a 2, and the sciatica was totally gone. So it was just not bothering him at all. 3 weeks later, he came back again, and he reported that after his third treatment, his low back pain was down to a 1 or a 2 out of 10 on average, and it was coming on once in a while as opposed to being there most of the time. So this patient decided to do 2 to 3 more treatments for good measure. As I'll discuss in an upcoming slide, with prolotherapy, I do a physical exam to determine which areas seem to need a prolotherapy injection, and that's indicated by there being tenderness at these points that I palpate. And so with him, he'd come back and say, well, I'm still feeling a lot better, but I want to make sure that my connective tissue is as healthy as possible. So I'd assess him, and if we found some tender points, I would inject them anyways. So he was just being very prophylactic with his health. So what we started doing, rather than treating him every 3 weeks, then he'd come back in after, say, 5 weeks, and then after a few months, then after 4 months. And so at this point, I haven't seen him for over 6 months, and he's coming in soon. But we're just kind of trying to stay on top of things as best as possible, but he's been doing very well with the treatments. In terms of prolotherapy, so the way that prolotherapy works is we inject a hypertonic solution of something called dextrose. Dextrose is just another name for glucose, which is the same sugar that floats around in our bloodstream. And so a hypertonic solution basically means it's a preparation of dextrose that has a higher molecular concentration than the normal molecular concentration in the tissues of our body. So the way I describe it to patients is I'm basically injecting a blob of sugar into the area that's experiencing difficulty. And when the body sees a blob of sugar somewhere, then it says that's not supposed to be there. So it brings blood flow to the area to try to flush that sugar away. And wherever your blood flows, it brings platelets with it. Platelets, of course, clot your blood when you have a wound, which is good. But if you cut your arm, the platelets come to the area to stop the bleeding, but they also release growth factors to help promote the formation of new tissue. So these growth factors help to promote healing, essentially. So when we inject the blob of sugar into the damaged area, brings more blood flow, platelets are there, they release growth factors, and that's believed to be why prolotherapy works. As I've alluded to already, ozone basically makes it all work better, it seems. Traditional prolotherapy is if you look up videos of traditional prolotherapy on YouTube, you can find some videos where it literally looks like the doctor is trying to stab the person's body to death. It looks like a very aggressive, quite frankly, uncomfortable process. And traditional prolotherapy has been done that way for almost 100 years now. It's a very long-standing therapy, and it does work to do it that way. However, What I found in my experience is that when we combine the prolotherapy or the PRP with ozone, we can get away with doing much fewer injection points, but we can also get away with using the therapy in a much more gentle way, where we don't have to be sort of jabbing the area repeatedly to try to make the therapy work better. So that's not something that I came up with on my own. This is, ozone combined with prolotherapy, which is sometimes called Prolozone, or ozone combined with PRP. This is something that's commonly taught at ozone conferences, and it's done all over the place. So it's something that I've definitely found to work well in my practice, and I'm able to get away with doing minimally invasive Prolo and PRP. Now, PRP, in contrast to Prolo, is, as I've written down here, essentially PRP is souped up Prolo. And with PRP, what we're doing is drawing the patient's blood, we spin it down in a centrifuge to extract the platelets, and then we inject the patient's own platelets back into their body in the affected area. So instead of injecting the blob of sugar, we're injecting the patient's platelets into the area. And so where with Prolo, we inject the blob of sugar, the blood comes, the platelets come, and they have a reaction in a favorable way with growth factors. In this case with PRP, we're just injecting the platelets right into the affected site. So we ultimately can get a higher concentration of platelets in the area, thus more growth factors, thus we see a stronger treatment effect. The procedure of Prolo or PRP, subjectively, they look and feel identical to the patient. The difference is that in one treatment we're using sugar plus a locally acting anesthetic called Procaine, and then with PRP we're using the platelet extract plus Procaine, and then ozone is administered for both. So first, an assessment needs to be done to determine which areas need treatment, and I have a slide coming up that I'll talk about that in a little more detail. So a physical exam is done to determine if the therapy is indicated, and if so, which points need to be injected. And we do have the diagnostic ultrasound machine, so we'll sometimes use that to aid in the diagnostic process as well. And then once we've determined the points that need to be injected, then the needle is advanced into the desired location. The Prolo or PRP solution is infused, so just like a typical injection. Once the PRP or Prolo is infused, then we leave the needle in place. We clamp the hub of the needle with some hemostats. We take the empty syringe off the needle, and then we have a second syringe full of ozone all ready to go. So we attach that to the same needle, infuse that into the area, and then we remove the syringe needle combo. So that way we're able to get two different substances into the same area of the body, but only one needle poke, so it's more comfortable for the patient. And then thanks to the ozone, there's no fenestration required, so that kind of jabbing type of prolotherapy that sort of is the traditional way of doing it, they call that fenestrating the area, which my understanding means poking little windows into the area, and by poking those little windows it causes more inflammation and more motivation for the body to bring more platelets to the area to try to heal the damage that's coming from the little microscopic amounts of damage that are happening from those needle pokes. So in terms of assessing a knee, the areas that I've circled in black, those would be areas that I would be pressing down on to try to see if there's a tender spot there. The examination of a body area to see whether Prolo or PRP is indicated, it's a little bit unique. It's not like assessing muscles or assessing range of motion or even assessing nerves. It's a fairly deep palpation, and when we find deeper tender points, those are referred to as enthesopathy points. Enthesopathy points are where the bony enthesis, which is where the ligaments or tendons attached to the bone, is irritated or inflamed or damaged. So when we palpate deeply to assess those bony enthesis points, the points that come back as being particularly tender are the points where we would want to do the Prolo or the PRP injections. So in the case of the patient with severe osteoarthritis, for one of his knees, where the X's are indicated, that's where I wound up doing the injection. So the X on the right was the injection right into the knee joint, and then the X's on the left, he had some deep tender spots at the superior and inferior aspects of his lateral collateral ligament. So I did 2 injection points on the outside of that knee, and that's roughly what we were doing with subsequent treatments. I treated this patient with the severe osteoarthritis recently, and we found no tender spots in the outside of his knees, which is fantastic because that's indicating that the underlying tissue is becoming quite a bit happier and healthier, so we didn't have to do that. So now he's only getting injections into the knee joint itself because the exterior tissue is becoming healthier again. Why does prolotherapy and PRP work? For something like a muscle tear that's fairly obvious, you inject platelets and thus growth factors into the damaged area and helps to heal the muscle tissue. For arthritis, an injection into the joint is fairly obvious because that's helping to repair damaged tissue inside of the joint. But with the last patient with the severe osteoarthritis, why inject those external points? Part of the motivation would be that if you have damaged tissue, you should probably do something to try to repair it. But the main reason that I'm recommending that treatment for this patient is to help improve his joint stability, because if his knee is slightly unstable because of some compromise of his lateral collateral ligament, then his knee joint is going to be subjected to some unnatural wear and tear. Essentially, the joint is going to be slightly wobbly, and when the joint is slightly wobbly, then the inside of the joint is going to have some inappropriate friction occurring, and that's going to make it harder to get his knee better, but it's also going to make it more likely that when we get his knee as healthy as possible, that we don't want it to start getting re-irritated again because of essentially an unstable joint or a less stable joint. A good example of this is looking at low back pain, or a bit of a different example of this is looking at low back pain. So say a patient does some heavy lifting, they damage a ligament in their low back, and then that would ultimately lead to a loss of stability in their low back. The body wants to compensate for a loss of stability at all costs, especially when it involves the vertebral column, because inside your vertebral column you have your spinal cord, which of course is very important. So your body will say, well, the ligaments are no longer as viable as possible, so we need to keep that spinal cord protected, so we need to keep that vertebral column nice and stable. So in the absence of optimal ligament integrity, then the body is going to engage muscles to try to compensate for that. So the surrounding paraspinal muscles, for example, will tend to get tighter, and that will make the vertebral column more stable, which is important. But unfortunately, that's also going to impinge the nerves, because nerves travel by the muscles. When the muscles get tight, they can clamp down on the nerves, and then that can lead to either local pain, so low back pain, or it could lead to sciatica or pain down the front of the leg or whatever it happens to be. So a classic thing that I see with patients who are suffering from long-standing pain issues is they'll say, every time I go in to see the physiotherapist or the massage therapist, or I go to see my chiropractor, they're always commenting on how, my low back or my neck or whatever area is affected is really, really tight. And I always have these rock hard muscles, and I stretch and I massage it and it gets better, but then it tightens right up again. And that's likely because of this type of chain of events. If you have a loss of integrity of the ligaments or the tendons that are helping to maintain stability in an area, then there's going to be compensatory muscle tightening, and your body's basically saying we need to keep these muscles tight because we need to keep that stability in check. So in the patient case with sciatica, I didn't do anything to directly treat his sciatic nerve, but by improving the ligamentous integrity of his low back and, in his sacroiliac joints, and improving the integrity of the tendinous insertions for his external rotators of his hip by injecting his lateral sacrum and his posterior greater trochanter, then that built up the stability again. His muscles were able to relax, and the sciatic nerve is no longer being impeded upon. We see this type of pattern with whiplash injuries all the time as well. So the whiplash stretches out the ligaments in the neck, then the surrounding muscles get tight, causes nerve impingement, and there's local pain or pain down the arm or whatnot. We see this in sports injuries as well. Somebody gets whacked on the side of their knee, it stretches out or damages the ligaments there, and then they get issues with that down the road. So treating ligaments is incredibly important for a lot of cases that do not heal up on their own or don't fully respond to other treatments. And then the aging process can also have an impact on ligament integrity, which I'll go over in an upcoming slide. Here's a little visual example of ligament laxity. So ligaments are like elastic bands. They can stretch out a little bit, and if they're stretched out a little bit and then the tension's taken off of them, they'll go back to their original formation. If you overstretch a ligament, it's similar to overstretching an elastic band, where it will try to return to its original shape as best as it can, but it's going to stay a little bit stretched out, and that ligament staying a little bit stretched out is going to lead to a loss of stability in the affected area. Ligament laxity is also proposed to be a possible natural consequence of the aging process. Common stereotype is that as people get older, getting into their 70s, 80s, and beyond, then they'll say, I'm shorter now than I used to be. And the understood mechanism as to why that happens is the intervertebral discs, so the discs between the vertebrae, they start to become a little bit dehydrated, and as such, they're not quite as full as they had been. And that can be problematic because as much as an intervertebral disc acts as a cushion between the discs, it also functionally acts as a spacer as well. So if you look at this diagram, where beside the letter A on the right, the intertransverse area ligaments in red are spaced out properly. They're holding those two transverse processes with proper proximity to one another, and they have a nice kind of a tautness or a tension that's appropriate. If this patient, as the patient begins to age, then if the disc, say on the left, or the arrow on the left pointing to the disc below that one, starts to get smaller functionally, then the transverse process is going to start sitting a little bit too close to the transverse process below it. So I've drawn in black kind of what the new location of the transverse process might be looking like, and I've overemphasized it to make a point. But you can see that beside the letter B, where the green ligaments are now no longer nice and taut, they're a little bit loose, and so they're not kind of maintaining that structural stability as optimally. So once again, this is a dramatization of what would actually be happening, but if there's a little bit of loss between many, if not all, of the intervertebral discs, then there can be a net ligament laxity starting to build up, and that might lead to some issues with neck pain or back pain, or potentially joint pain coming up in other areas of the body. So sometimes when patients come in and they're in their 70s or beyond and say, I'm having issues with my low back, and I assess them and say, well, your ligaments are having an issue, and they say, well, I've never been injured, there's nothing that's been stretching out my ligaments in the past, then I'll say, well, maybe it's part of this side of things, and if they get better from prolotherapy or PRP, then we know it was very likely a ligament related issue. So it's kind of the proof in the pudding that this could be what's going on. In terms of the safety of PRP and prolotherapy, it really depends on a number of factors. Generally, if we're using good, safe technique, the practitioner has a good skill level, the therapies are safe. The area being treated definitely has an impact on the safety. Anytime that we're treating over the thoracic spine, for example, we always use a diagnostic ultrasound so that I can see on the screen, there's the rib, there's the lung, and I'm going to make sure that the needle on the screen is not getting anywhere near that lung, because that's, of course, a higher risk zone to be treating. The practitioner skill level is important. Anyone who's doing prolotherapy or PRP would be doing a significant amount of extra training to learn how to do the therapy properly. The insertion speed of the needle is important. So if we insert the needle very gently, then it's very unlikely that we'd be able to damage any important underlying anatomy. We try to use the smallest needles possible. So as long as the needle technique is appropriate and therapy is being done by a practitioner who knows what they're doing, then generally it's a safe therapy. If a patient has an allergy to the anesthetic that's used, or an allergy to a severe corn allergy, which is what most dextrose is sourced from, then those could be contraindications. You can get dextrose from beets, so it's a circumventable problem. And then some patients will have issues with hypoglycemia, i.e. a blood sugar drop, or hypotension, i.e. a blood pressure drop when they get an injection. So some people can feel a bit woozy or faint, but usually when we're using the minimally invasive technique, that it's very rare that happens. Limitations to prolotherapy and PRP. In my experience, Prolo and PRP can work incredibly well, and when the physical exam findings and the history support the use for them, it has a very high success rate in my experience. The question, of course, is always, are we treating the right thing? So if the patient has a misalignment of, say, a vertebrae, for example, they'd probably want to see a chiropractor or an osteopath to do some structural work. If they have tight muscles, they might need to stretch or just get a massage. If it's a nerve issue, then we might want to use something like neural therapy or neural prolotherapy. As I mentioned, if the ligaments are damaged or compromised, then the muscles get tight, then the nerves get impinged upon, and then you can get nerve issues as a downstream factor from a ligament issue. However, in some cases, we need to actually get the nerve back on track first, or even after prolotherapy, sometimes we need to do work on the nerves because they get stuck in kind of a pro-pain state. But that's all determined through the physical exam findings. So if the other underlying causes have been ruled out or they're being addressed, then if there seems to be an indication for Prolo or PRP, then oftentimes we'll see success with either of those therapies. Another limitation would be patients with a needle phobia. I've had patients who have come to see me saying, we heard that you're really good at treating pain. And then I assess them and say, you know what, you really need some prolotherapy. And they say, oh, how's that done? And I explain it, and they say, I am deathly afraid of needles. I would rather suffer with this pain than have you poke me with a needle. And that would mean that we can't do Prolo or PRP for that patient. But once again, if we're using a minimally invasive technique, then some patients who are really, really deathly afraid of needles, they'll let me do 1 or 2 points and find that, oh, you know what, that really wasn't that bad, because we're not using the really more aggressive fenestrating technique. Here are some references on prolotherapy. And PRP. And you can, of course, pause the video to look at those in more detail. I hope that you found this presentation to be informative. Here's the contact information for my clinic, and thank you for your attention.